Hi, this is Dr. Bob Dannenhoffer, Public Health Officer in Douglas County with another of our Facebook Live. Now these sessions we've been doing twice a week for over a year now, and this is a chance for us to answer your questions. People in Douglas County have lots of questions, lots of good questions, and this is a chance for you to ask your questions and for us to answer them. The good news is that the pandemic is getting so much better that the number of questions, the number of people watching has gone down a little bit, which is perfectly acceptable. I mean, I would hope certainly in this time of the year that we do have less and less worry about COVID and more worry about other things and more attention to other kinds of things like graduation and sports seasons and music on the national and whatever else. So that is great with me. So if you have questions, you can do them two ways. One is you can put them in the chat, but the way you can be sure that your question can get answered, especially if it's a complicated question, and you'll see this a little bit later on, is if you put them at Facebook questions at douglaspublichealthnetwork.org. So as always, we start with the world view and then move down to the view in Douglas County, and you'll get a sense of how things are going. So in the world, it's definitely improving. There was a big fourth peak last month, and that's getting better. Places that had a lot of disease in the fourth peak, including Europe, the UK, and Israel, all doing very well. And especially the UK and Israel have very low rates. In fact, the UK went a whole day without a single death. Now, the UK is not enormously big, but about a third of the size of the US. And so for them to go a day without a death is amazing, given the total amount of disease that they had earlier on. Also, Israel, which has done a very good job with vaccination and had a really high rate of disease, about 70 per 100,000 per day, back a few months ago, is now down to 0.2. So it's a decrease of 300-fold. So really pretty amazing. However, it's not over yet, because it's especially bad in South America, especially bad in Colombia and Uruguay. So these are two areas that are really having a tremendous amount of disease. Remember that Uruguay is on the other side of the equator, so this is getting into their winter time, and we're seeing a big increase in disease. And that should worry us a little bit, because we're going to have a winter too, I understand, in 6 months. And when we do, the concern is that if there's still some disease circulating, it will get worse. It's also bad in a couple of other unusual places. India, we don't know what's going on in India. It has gotten so politicized in India that I don't know what in the world is happening with India, but when I talk to friends who have family or relatives in India, they say it's still pretty bad. And then it's bad in other funny places, bad in Mongolia. So if you think of the map of the world, there's China and Russia, and in between them there's a little oval-shaped country called Mongolia, which sort of balances off China and Russia. So they've gotten vaccine from both, vaccinated a lot of people, and yet they're continuing to have lots of disease. Thought that it's due to a variant, although there's not very good variant testing in Mongolia, so we really don't know what's going on there. We do know that in South America, it's mostly the P1 variant. In India, it's mostly the 617 variant. And in China, they're starting to have little outbreaks from 617. Taiwan had a 617 outbreak. Australia had a 617 outbreak, so it is concerning. In the U.S., it's really quiet. We're down to about 5 cases per 100,000 per day overall in the U.S., which is one of the lowest rates we've been in a year. No real hotspots, although there are little brush fires in Colorado, in Wyoming, in Louisiana, and West Virginia. The rest of the country is really pretty quiet. Oregon, we're down to about the national average at about 6 cases per 100,000 per day, but Douglas County continues to struggle. We're at 15 cases per 100,000 per day, and we've had some days as low as 5, but some days as high as 30, and a very high number of people hospitalized. Down a little bit today, but we've been over 10 now for a couple of weeks, and most of the people hospitalized are younger. So when I looked the other day, 10 of the 12 were younger than me. I'm 65. Where 10 of the 12 were younger than me. And when we look at the recent deaths, the deaths used to be mostly people who were above 70, and now the median age of death is 70. All right, keep going. Bad audio. I must have done something wrong. Just speak up. All right, I'll talk up. All right, so that's it. Now, when we look at the Douglas County cases, there are a couple of things that really show up with the Douglas County cases. Let me see how that works. That show up with the Douglas County cases. One is that the Douglas County cases are getting younger, and they're almost all unvaccinated. So when we looked last week, 110 out of 111 cases were unvaccinated. One case was in somebody who was fully vaccinated and they had a mild disease. I mean, that's just astounding. Just astounding when we consider about 50,000 people in the county have had one dose of vaccine and about 60,000 people have not had vaccine. For 110 cases to be in the unvaccinated group and one case to be in the vaccinated group really shows how incredibly well the vaccine works. So we would encourage people to get the vaccine. And there's lots of vaccine out there. So the pharmacies have it, the clinics have it, we're having our drive-through. So lots of places to go ahead and get vaccine. All right, let's see what kind of questions people have. Okay, so Dennis says, you have explained why there are two different vaccination counts because the VA and Cow Creek reporting differently. This is a serious problem. Absolutely. And has caused a lack of belief in the system. I would agree. Is there any way I can find a list of those uncounted vaccines to show my friends who use the New York Times or the OHA that uses the alert for the counted vaccines administered? The answer is I can't. They're done in a different way. So the Oregon vaccines are counted on the basis of where you live. The federal vaccines, we are told, although I've not been able to verify this, are done by the place you got them. And so there's no way to totally reconcile those. So we have tried to reconcile those in a couple of ways. One is I have a list of everybody's gotten vaccinated, so I know the people who've been vaccinated. We know that the people at Cow Creek Tribe have administered so many vaccines, and they've given us a number. And actually, the feds had that number that they briefly counted as the number of federal vaccines. And then similarly at the VA, the feds briefly said that number is about 11,800. Since then, so 11,800 out of 94,000 people who are eligible makes up a difference of about 15%. And that's the difference between the New York Times and the OHA and what we count. The OHA recognizes this problem. They've allowed us to use our count for our internal workings and when we get to the 65%, although there's really no way for them to mesh this together. And I have a weekly conversation with the head of the OHA and the person who's in charge of data, and it is an incredible problem. So the next time we have a pandemic, and way before then, we have to figure out a way to reconcile this data. There is a bill before Congress introduced by Senator Warren that would do that, but I will tell you the way things work in Congress, it is not going to be ready for this pandemic. Now, the interesting thing is that the Cow Creek Tribe has spent an incredible amount of time and effort entering those vaccines into both systems. And so now when they get entered into the Oregon system, I can see those, and they've been working diligently on that for the last 3 weeks. And every week we're starting to see more and more of those vaccines. They're up to about 1,200 of the 4,000 they think they administered. And so we'll continue to get that data. So we expect with time that the data issue for the Cow Creek are going to be taken care of. The data issue for the VA is not going to be taken care of. Yet when I talk to the people who actually administer the vaccines, their number is very close to the 8,000 that the feds briefly reported at one time. So this is an incredible frustration. There's a question later. About what we need to do to prepare for the next pandemic, and that's one of the things. So Donna says, my niece, her husband, and 4 school-age children, all unvaccinated, are planning a trip to Roseburg to visit my 94-year-old fully vaccinated mother. They are traveling from Tracy, California. This is worrisome for me. Am I overreacting? Well, it would be worrisome for me too. My mom is 91, and we're planning a reunion back east. So unfortunately, I'm not going to be there, but my brothers and sisters will be there. My wife is going to be there. My grandkids are going to be there. And what are they doing? Everybody's vaccinated. All the people who could be vaccinated are vaccinated, and they're going to do it outdoors. And the people that everybody's coming from have relatively low rates of disease. So except for the 3-year-old and the baby who can't be vaccinated, everybody else is going to get vaccinated. Everybody else is going to be vaccinated, and they're going to do it outside. Now, in this case, there are things to, this is in the middle. There are things that are good. The things that are good is that the 94-year-old grandmother is vaccinated. The other thing that's good is that Tracy, California, has a relatively low rate of disease, about where it is in Oregon, about 6 cases per 100,000 per day. So that's a good thing they're not coming from an area like Uruguay or a place where there's a lot of disease. So that's the good. The other good is they're coming to Roseburg this time of the year. The weather is usually beautiful, and you could do it outside. So all those things would be to the good. Grandma's vaccinated, they're coming from a low risk area, and you could do this outside. The problem is that the niece and the husband aren't vaccinated, and they have some risk of coming with the disease and some risk that 94-year-old grandma, her immunity is going to be weak because she's 94 years old, and that she's going to be at some risk. So this is one of those middle of the range. It's not the safest way you could do it, which would be the way they're doing it for my mom. And it's not totally unsafe because they're not coming from a high-risk area and grandma's vaccinated. So if they could get vaccinated, it would be great. If they could do it outdoors, that would be great. And certainly if they were sick, they should stay home. So Lane says, and this was an example of a great question I could do beforehand, because I could actually look up Tracy, California, in there between Modesto and Stockton. That could help me to know exactly what their rate is. So put your questions in, Facebook questions at douglaspublichealthnetwork.org. So is the state going to start using the new names for variants? I have not heard that. That was a question that we have a meeting tomorrow that we're going to deal with. So again, the system of naming variants was really, really, really complicated. It was complicated because when you name a variant, you could name it by the change in amino acids. So you've heard of people talking about the D614G or the E484K. And so there's one way to do it. Another way to do it is by talking about the lineage, and that would be the P1 or the B117 or the 617. Or you could do it where it was first noted in the UK, South Africa, Brazil, or India. The problem is that once you start putting names on things, it just makes it really hard. So we're trying to get away from place names. So 1918, there was a terrible flu. I mean, really a terrible, terrible flu. It's a pandemic flu. It has been called the Spanish flu. I think there's incredibly good data that did not start in Spain, but really good data that it started somewhere around Fort Riley, Kansas. So I don't think we would have wanted for history to record this as the Kansas flu. I mean, Kansas didn't have anything to do with it. So I don't think we would want to call this the Kansas flu, which would be the correct, which would be the way to do it if you did it by geographic names. So I think they're trying to go to names other than that. So rather than calling it Wuhan, because we're not sure it started in Wuhan, it may have started in the bat caves or whatever. So they call it COVID-19. And I think on the variants now, rather than calling them the UK variant, we're going to call it Alpha. Rather than calling it the South African variant, we're going to call it Beta. Rather than call it Brazil, we're going to call it Gamma. And rather than calling it India, we're going to call it Delta. So Alpha, Beta, Gamma, Delta. And that's where we're going to go. I don't know when the state is going to start using it. I will try to use it. Helen, I have a friend who says she's allergic to metals, claims they are in the vaccine, and is still reluctant. Depends upon which metals. I mean, there are a lot of different metals. Obviously, the vaccine is given in steel needles. There's surgical steel needles, so there's not a lot of there's not a lot of leaching of chemicals. So it makes a difference which metal she's allergic to. Most people are allergic to nickel. There's no nickel in this. So so Helen, if you get back to us with a more specific question about which metal she's allergic to, and then we'll see if there's any of that metal in the vaccine. So I'm fully vaccinated, both vaccines plus 14 days, yes, and was exposed to a known case. Should I still quarantine for 10 to 14 days? The answer is you do not need to quarantine, which means stay home and stay away from others, but you should self-monitor. So you should look for symptoms. Again, of the 50,000 people who've received a vaccine, only one had disease. It's not zero, but pretty close. So your chance of getting this illness is very low, and so you don't need to quarantine, but you should self-monitor. So I have an almost 11-year-old, and he's going back to school. When will his age bracket be able to get the vaccine? Debbie asks, I don't know. They're doing the studies now on kids up to age 12. We should get them later on and then the end of the summer, and then we may know a little bit better about when they're going to get it. Now, I will tell you the risk-benefit analysis for different ages is different. So when you look at somebody my age, an old guy, the risk for the vaccine is very low, right? All of the side effects that they've seen, like the myocarditis and the clotting and whatever, have not been shown in my age group. So the risk is pretty tiny, and the benefit's enormous, because if I get sick, I probably have a 1 or 2% chance of dying. So my benefit of 1 or 2% chance of dying and the risk from the vaccine being very low, it's totally skews in favor of doing the vaccine. When you get to 11-year-olds, so 11-year-olds probably are about the lowest risk. So there seems to be a little risk in the first few years, and then more of a risk as you get to be a later teen. But at 11, the risk is very low, and so when the risk of the disease is very low, then you have to do that against the benefit of the vaccine. So the risk-benefit analysis at age 11 is different. So we're going to have to see that when it comes out. Yeah, so Clover says, why are people so worried about spike protein from vaccines traveling through the body? Isn't that what's supposed to do? Is it all hoax stuff, or is there anything to watch? So I watched this guy Brian Bridle, who's a veterinary immunobiologist, and he did this breathless YouTube video that, did you know that when you give this shot in the muscle, it doesn't just stay in the muscle, it goes to the rest of the body. And it was like, oh my God, that's scary. The answer is, well, whoever thought it stayed in the muscle? So if you got a shot of insulin in the skin or in there, you wouldn't think it would just stay in the muscle. It goes to the whole body and brings your blood sugar down. If you get a shot of epinephrine because you're having an allergic reaction, you don't think it's just going to stay in the muscle. It goes to the whole body to help you do it. If you get a shot of antibiotics in the arm, you don't think it's just going to stay in the arm and only treat an infection in the arm. You expect it to go to the whole body. So this breathless idea that this vaccine goes everywhere was like, okay, not a surprise to me. So much of it stays in the arm, and we certainly know that happens when you give antibiotics, that the amount in the arm is greater than the amount in the rest of the body, but it does go out everywhere. So this goes everywhere, and then, not surprisingly, the spike protein goes everywhere. And this guy's supposition is it's the spike protein that causes inflammation in the body, and it may well be. I mean, what we do know is that there's very little virus in the bloodstream. So if you have somebody with the disease and you collect their blood and you try and find whole virus, you can't find it, but you can find a lot of viral fragments in the bloodstream. So not shocking that it's the viral fragments that are causing what goes on. So I'm not quite sure what the great news was. I watched this whole thing thinking clearly there's going to come up with some great new news, and it was like, yeah, you get spike protein in the rest of the body. I mean, that's not shocking. I mean, you don't have very many immune cells. You don't have very many immune cells just in your arm there. You would expect the whole body is going to work on the situation. So I thought that was weird. So I did the magnet test. So here was the trouble in the magnets. So we had this super strong magnet, didn't stick to anything. It was not a very exciting video. And what I tried to do was to parrot off a video that was there, but because it's been so de-hoaxed, they were all taken off the internet, so I couldn't even really compare it to the one that people showed, but I couldn't get it to stick to anything. So, and the deal is, since anything that was magnet test COVID got pushed off the internet, I didn't even finish it, but I couldn't get it to stick to anything. Again, if anybody else could have a magnet stick to anything else, please let me know. Even with a super strong magnet, it couldn't stick to my body. Now, the super strong magnets are really strong, and they're a little sticky, so they might stick to your skin, but has nothing to do with the vaccine. Okay, so one of the questions that came up was, what should we learn from this pandemic for the next one? And I probably could go on for hours, but there are a couple of things. One is, really in this modern age, we must have interoperability of data. Going back to the question here,
about the VA system not talking to the state system, that is shameful. I mean, that is just absolutely shameful because it creates confusion, creates different numbers, and it creates this level that nobody's really leveling with me about what's going on. And that is, for me, a shame because there is a lot of complicated information. And anytime we can't explain it to you crystally clear about what's going on, that the data varies from 35 to 41 to 47 to 50 to 53, it just is, to me, just absolutely shameful. So one of the things that we have to work on before the next pandemic is interoperability of data. The other thing is when you look at, for example, the definition even of a case in different areas is different. So some states consider a positive antigen test, others don't consider that. Some consider positive antibody test, which I think is silly. Others don't. You may have seen a thing from California where a state, where a county, Alameda County in California, the rules were so complicated they couldn't follow the rules, and they miscounted the number of deaths. So really, before the next thing, we have to figure out a way to get our act together. This is not really a political issue. It's not really a scientific issue. It really is an issue of the various governments and whatever getting together and agreeing on some interoperable things. Could you imagine if you were traveling and you're driving in Oregon and then get to Washington and you have to drive on the other side of the road, or you get to Washington and the street signs look all different? Oh my goodness, think of how difficult that would be. So we really need to have interoperability. The second thing we need to plan for in the next pandemic is that we have to recognize that business strategies during regular times, during regular times won't work during an emergency. So many of the hospitals over the last 20 years, so when we look at protective equipment, gowns, gloves, masks, and whatever, back in the 90s, almost all that stuff was made in the U.S., and then was in these big warehouses, and then hospitals would order a big amount, they'd have a big warehouse, and then they would have some there. If something happened with the production chain, there's a lot in the warehouse, it didn't really make a big difference. Over the last 25 years, lots has changed. One is much of the production of this stuff has gone to places where they can make it cheaply. So the rough was in 95% of the stuff was made in the US. By 2020, 95% of the stuff was made overseas. And the other thing that happened, it was delivered just in time. So rather than hospitals having big warehouses, they had a storeroom where they had 1 or 2 days worth of stuff, and they would get delivery every day or every other day, and then they'd fill up the storeroom and use it, fill up the storeroom and use it. But what happens when there was an international crisis such as this is we had to rely on this stuff from China. They were going through the first wave of this, and they were using all the PPE themselves. And that's why we had this enormous PPE shortage. And really countless people working in the U.S., working either in healthcare, working in emergency medical services, or working in frontline businesses like bus drivers and whatever, died because there was not adequate PPE at the beginning. That is really shameful. Now, not blaming anybody, but I'm just saying that what we need to do to prepare for the next pandemic is we need to have stockpiles of the stuff that we draw down so that in case there's something, we don't panic in the second week when there's a thing. So my sense would be we should have 30 days of supplies at a hospital or hospital chain level. We should have 30 days supply at the state level and 30 days of supply at the federal level. Doesn't have to build them up tomorrow, but we should build them up for a while so that the next time a pandemic hits, we're not struggling to go ahead and figure this out. The next thing we have to recognize is that when we look at the bad disease that we've had in the last 105 years, it has been almost always gone from animals to people. So flu almost always goes from animals, either birds or pigs or both, to people. Ebola went from primates and bats to people. SARS went from bats to civet cats to people. MERS went from bats to camels to people, and this one, we don't know where it came from, but presumably from bats and then some way to people. Catch the drift here that almost all of the bad disease we've had here has gone from animals to people. And so we really have to pay attention to what's out there among animals that could spread to humans. Now, the last 3 bad ones were all coronaviruses. So the fact that we should be studying coronaviruses seems pretty clear, but influenza is the other one to study. Influenza is SARS and coronavirus are really interesting. Influenza is absolutely fascinating. There's influenza viruses and different ones among all kinds of different animals, among camels, among whales, among pigs, among birds, and the way these things recombine and whatever are truly remarkable. So the biology of influenza is just incredibly complex, and we need to study these things because where we're at now, we should be able to develop a vaccine quickly. Now, in the past, it would take a year or more to develop it. We now brought that down to about 8 months. But I think what we need to have ready is we need to have ready the capability to do this so we can get a vaccine ready in a month or 2 rather than taking that long time to do it. And some of the reason was we needed to actually build the factories to do this. We actually had to come up with the syringes to put it in. We had to come up with the strong glass that could store the stuff at the low temperature, none of which we had, and we had to move along the way. So the story of this development is really fascinating, and that you wouldn't think that pelletized dry ice was going to be a big problem, but it was an enormous problem because we kind of doing it on the fly. So what we need to do is we need to have all this stuff ready to go so that there should be an emergency. We don't need to think, oh God, where in the world are we going to get strong glass? Where in the world are we going to get pelletized dry ice to make this work? We really need to have those things ready so that we can get it done. So those would be the top 3 things. 1, we have to recognize that the regular supply chain doesn't work in an emergency, and you have to prepare for that. It's going to cost a little bit of money, but not very much, because this stuff which is in the state and the federal supply can get used. It doesn't have to just sit there. It can be, use it and then replace it, use it, replace it. So it basically costs, and if you did it over 3 years, it would cost 1/36 of your PPE cost. Hospitals spend a lot of money on PPE, maybe 10% of their budget, but 1/36 of 10% raises their total amount by only like 0.03%. I mean, it's just a tiny, tiny percent that it raises their budget for PPE. So I think we need to do that. The second is study these viruses that are out there so that we can be ready the next time one shows up, because they will. What happens in these viruses is that they circulate among bats or whatever they circulate among, and they continue to mutate until they find the one that hits people. Now, most of the mutations out there are just nonsense mutations that are not going to affect anything, but some very crafty ones will get there. And the concern is that if you had a bad flu like we had in 1918, if we had a bad other thing like SARS. Now, SARS was really a very serious disease, just wasn't very contagious. Now, imagine if you had one that was both contagious and serious and spread asymptomatically. That would be really, 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 really hard to fix. So that would be it. And then the third one is we got to figure out a way to do better data interoperability. We are never going to get people's confidence until we can do that. So what is DPHN doing to combat vaccine hesitancy within our county? So we are working with internally doing stuff like this. Unfortunately, the people who are probably listening to this are people who are not particularly vaccine hesitant. We are working with our doctors in the community. So the great group called the SIPA, a group that I had a lot to do with over the years, is helping us because we think people trust their own doctors. They're working with their own patients to work on vaccine hesitancy. We're trying to combat some of the misinformation that's out there, and we are going to where people are. So rather than this is coming from on high from CDC or somewhere else, we're meeting people in Milo and Tiller and Camas Valley to help them get the vaccine. Again, Frank, if you have other suggestions, we would be happy to do it. I have spent more hours than I can count thinking about how to deal with vaccine hesitancy, and yet nobody's got a great answer. So Veronica says, I have 2 friends who are vaccinated now have AFib. So have we heard of any connection between the vaccine and AFib? So AFib is something called atrial fibrillation. It's a heart rate abnormality, which is common as we get older. So what typically happens in the heart is that there's a thing called the SA node, the sinoatrial node, that makes the little electrical impulse that then travels across your atrium into the next area called the atrioventricular node, and then the atrioventricular node sends us to the heart, and that's where we get the heartbeat. So we've all seen that thing on TV. So that first little bump is called the P wave. That's from the SA node, and then it goes to the AV node. What happens in atrial fibrillation is that instead of having one good common pathway, it's got a lot of different pathways, and these people have fast and irregular heartbeats. It is a common thing as people get older. So I'm not sure I've ever seen it in a kid who didn't have underlying heart disease. I'm trying to think if I ever did, but it's not at all common in kids. But it gets more and more common as we get older and older, and so then you start to see it at age 40 and then 50, and by the time people are 60 or 70, many people have atrial fibrillation. There clearly is some association with the vaccines and myocarditis, but not with rhythm issues. And one of the ways we would know this is a lot of cardiologists out there who see lots of new people with AFib all the time, and if they saw a great increase related to the vaccine, they'd say, "Geez, this is funny. I used to see 2 a week. Now I'm seeing 2 a day," and they've not seen that. We would also start to see in the VAERS reporting that there would be an increase in hospitalizations from AFib, or there would be an increase in the amount of people who are prescribing medicines for AFib, and we've not seen any of that. Now, could there be a connection? Absolutely. And I'm not saying there isn't, but it wasn't seen in the trial of 40,000, and it hasn't been seen in that group who were vaccinated before. They followed them out, hasn't been seen in that group, and hasn't been otherwise reported. So it's one of those things we should pay attention to, but it does not seem to be related to the vaccine. All right, let's see if we can get a couple more questions here. So again, talking about the variants, and I think that's an important one to do. The variants appear to be more difficult to control, and they're more difficult to control because all of them, the alpha, beta, gamma, and delta, seem to be more contagious than the original strain. The alpha, which is the B117 seen in UK, seems to be very well controlled by vaccine and by convalescent sera, so that if you've had the disease before, get it again, you don't seem to get it twice, or get exposed again, you don't seem to get it twice. If you use the antibodies from somebody who's had it, it does in the laboratory stop the vaccine, and the report among vaccinated people is that there's a very low breakthrough rate for the B117. We've seen that in the US, we've seen that a lot in UK and a lot in Israel, where those are the most common variant. That is pretty clear. The 351, which is the beta seen in South Africa, that one, the vaccine works less well. So where the vaccine worked 90% or greater for the alpha, it only works 50 to 80% for the beta. So the vaccine works less well, and the antibodies collected from people who have the disease also seems to work less well. We know a little less about the gamma, which is the P1 from Brazil, but there are numerous reports of people who had been fully vaccinated or previously had COVID now coming down with the P1, and we've seen this in Oregon too. So there's this outbreak in Oregon, there's this P1 outbreak in Oregon that has gotten people who were previously vaccinated, and so there's a real concern that P1 is not going to be as well controlled by the virus. Still don't really know about the 617. So that's what we got. I had a call today about somebody who was critical about our calculation of breakthrough cases. we report the breakthrough cases in integral numbers, so I'm not sure how you could worry about that. And that the rate of breakthrough is low. There is a complicated way to calculate that, and rather than bore you with the details, we would just say it's very low. All right, so so lots this week about where did this come from? Did it come from the Wuhan lab? The story is we don't really have any new data. So almost all the data that we have about what happened in that Wuhan lab, we had over a year ago. So there's nothing new at this point. I think we're just rehashing what goes on. And the leading theories are that it started in a bat in a place away from Wuhan. It was then somehow got to Wuhan. It could have gotten to Wuhan from a bat collector, because the Wuhan lab has people who collect bats. So it might have gotten there from a bat collector. Might have gotten there because people traffic in bats. So they sell bats for other purposes at these wet markets. It's possible that it came to the Wuhan lab to be studied and then left the Wuhan lab either because it was a lab accident, that certainly happens, or it left the Wuhan lab because it was intentionally released. And again, I don't know. There's no new data on any of this. If I had to guess, I would guess that it either got from the bat cave to Wuhan and out there through an intermediate animal like the pangolin, or that that a person had it, didn't quite know what it was, maybe a low-level person who didn't even work in the lab, who then spread it to others. In the end, it doesn't. It does make a difference in some ways. One of the ways it makes a difference is we really want labs to be very safe. When you're dealing with these dangerous things, we don't want people treating this cavalierly. You have to treat these things really dangerously, because remember, much of the bad disease we have here comes from other animals. So when you're dealing with sick other animals, you can't be cavalier about how you do it. You have to be incredibly safe about how you do that. And then once you have a lab with biosafety, and what you see is you see these labs and the people in these moon suits and whatever moving about, and that's great. But you really have to worry about the guy taking out the trash, right? Because the guys in the moon suits, if they got sick, they would presume it was from their disease, but maybe the guy taking out the trash wouldn't sort of recognize that this was related. So we really really should get to the bottom of this and figure it out. Okay, that's it for questions, which is great. So we'll call it a night. As I said, it's getting to be sometime. We're hoping people will do other things. Our staff has been incredible. So every Friday night, they've been working on this stuff. And believe it or not, some of them want to have a 3-day weekend. And you know what? I can't blame them. These people work incredibly hard. They work many weekends too. So this past weekend, we had our event at the fairgrounds. We're going to have again in another few weeks. And when we don't have an event at the fairgrounds, we have an event somewhere else. So this coming up week, we're going to do one at Two Shy Brewery. The week after that, we're going to do one at the Chainsaw Festival. The week after that, we're going to have another big event at the fairgrounds. So these people have been working really hard. So we're going to go ahead and stop the Friday ones after this. We'll do this Friday, but next Friday, in honor of summertime, we are going to hold off and just do these on Tuesdays at 6 o'clock. The good news is this will give more time for you to put your questions in. If there's an immersion question in there, like, oh, what's happening tomorrow, we'll answer it right away and then bring it to the Tuesday night sessions and repeat that so that everybody can hear it. But if there are questions which are sort of interesting questions, but nothing time sensitive, such as the ones we've had tonight, we'll go ahead and do them just on Tuesday nights. So again, I think we're getting near the end of this. It would really, really be great if we get more people vaccinated. We're about 52%, and our number of new vaccines is really declining. So we had a big event this weekend. We had all kinds of vaccine available. Didn't give very many. And so, again, if you want to get vaccine, please get it. If you have questions about vaccine, talk to your doctor. Give us a call. And talk to somebody who you trust about getting the vaccine, because it really does seem to work, and it really does seem to be really quite safe. So again, I would plead with everybody to go ahead and get the vaccine. All right. That looks like it for questions. This is Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. Be safe and be kind. Thank you.